We good?
Yep.
All right.
Off you go, Amy.
Hello, everyone. I'm going to do a case study on a patient I had come in just as a routine ultrasound last year, which was a bit of a... I thought it was interesting, but nobody else got excited about it, as per usual. So it was my first patient of the day, which is normally a liver clinic patient from RBWH, and that's exactly what this one was. So she's a 53-year-old female. She presented for a check of the liver, portal vein and the spleen. She's got a history of cirrhosis secondary to Hep C, and they just want to make sure that it's all looking good before they commence her on treatment. So I'm scanning away. I'm like, oh, you got any current problems? She's like, no. I said, and then I saw what I was looking at, and I'm like, any abdo pain at all in the past couple of days? And they're like, no problems. Oh, I think I had my gallbladder out about 20 years ago. I'm like, oh, okay. Anyway, so this is what I was seeing. So there's only two other sonographers in the room, so I'll point it out to people. This is the liver up here. This is actually 3 shots that I've jammed together. Doesn't normally look like this. Anyway, so liver up here. This is probably mid to distal aorta. And up here you've got it just a little bit wider than down there, which is unusual. And it's I measured it at 3.29 centimetres. So anything over 3 centimetres is considered a what do you call it? Aneurysm. Thank you. So I was like, oh, that doesn't look very good. And then I looked a bit closer and I'm like, oh my goodness, what's this little flappy thing going on here? So this is celiac trunk here, and it was very hard to tell where it ended up here, but it was quite close to the celiac trunk. And then I should have some videos. And then it sat there and flapped in real time. And I'm like, goodness me, this is looking like a dissection, but there's nothing wrong with this lady. She's not got any symptoms. What's going on? And so you can see on colour wave, the true lumen has a really high velocity flow because you've got a narrowing, it's like a stenosis, and then the false lumen has a more chaotic, slow flow because it's just kind of eddying around in there because it can't make its way out. So I at least found that the celiac was patent, which explains why it's not an unusual finding because she's got no symptoms, so that celiac's got to be patent. I wouldn't trust the aliasing on that. It's probably just my colour settings, so don't worry too much about that. Alright, so I rushed out to the radiologist and I'm like, oh my god, this person's got a dissection there on my table. Get them off before she dies. Anyway, so we decided that she should probably have a CT scan. So Dr. Singh actually wrote out the request and we did that. So as we come down, you can see the flap starting to happen. Comes all the way down. So the posterior part is actually the true lumen and the anterior is the false lumen. And you've got a bit of thrombus around there as well, just taking up some space. And then you can see it gets quite close to that celiac. This is the same thing in Sag. So fairly sizable. So the CT findings said that there was a dissection starting at the level of T9 and continuing to the origin of the truncus, and the celiac is actually partly fed from the lumen, so it does involve it, but it must be getting enough flow that she's not getting any symptoms. You also had thickening of the wall, and you've got that focal widening of the aorta. And good news is the renal arteries are uninvolved, so it's always nice. You don't want to have your renal arteries start to dissect as well. So I was like, right, let's get her out of here because I don't want to see her anymore. So we sent her over to DEM for assessment. She was then transmitted to the medical ward, and and then I know they talked to RBWH, but she wasn't sent to Brisbane, and I'm like, why on earth not? Like, aren't they going to do anything for this lady? And it turns out no. So this is just a bit of background information for everyone who needs a reminder on what a dissection is. So it's usually caused by a weakness in the wall, in the internal layer, and allows blood to seep through those 2 layers, and then you get your true and false lumens. The big risk factors are chronic hypertension, connective tissue disorders such as Ehlers-Danlos syndrome or Marfan's, if you've had a catheter introduced into the femoral artery and up into your aorta and they decide to scrape the wall a bit, that can do it as well. Trauma such as deceleration injuries, and then if you've got congenital abnormalities like aortic coarctation is a good one to decide to dissect on you. And also apparently vasoconstrictive drugs like cocaine, so maybe this lady had a very interesting history, who knows. So when they talk about aortic dissection, they classify it. There's two classification systems. They normally use the Stanford these days in a lot of the newer publications, and I think it's because, so Stanford just determines whether there's any involvement of the ascending aorta versus just involvement of the descending aorta. So A is ascending plus or minus descending, and B is just descending. And if you've got a type A, it's a surgical repair, and that's it. If you've got a type B, it depends on the actual dissection and its complications. So if it's a complicated type B, which is what Our Lady had, if type B is what Our Lady had, if it's complicated, that's when they're going to operate. So complications are like the malperfusion syndrome. So if it is affecting any of your feeding vessels, and so you'll get spinal cord ischemia, renal failure, mesenteric ischemia, that sort of thing. If the actual aneurysm around the dissection is more than 6 centimetres, if it's growing, so that's the impending aortic rupture, that's a complication. And if the dissection is actually propagating as well, that's another one. So an uncomplicated dissection is none of those things, which again is what Our Lady had. And I've already covered that. So uncomplicated, they just treat it medically. It's not even, they don't take it for surgery, they just keep an eye on it. So her aneurysmal sac was 3.6 centimetres. She had no symptoms. It was a type B, so that's why she didn't go to Brisbane, because I fully expected her to, but nope, she decided to stay here and have conservative management. So what do they do for that? So the idea is to try and reduce your systemic arterial pressures and to reduce the power of the left ventricle, so reduce the output of that left ventricle. And they do it by a lot of drugs that I don't really understand. So you want to try and keep your systolic pressure at 100 to 120 and your heart rate at 60 to 75. And as people know who've ever done a cardiac CT, that doesn't happen for a lot of people. So there's a fair bit of playing around with drugs for these patients. Also, there's recent evidence that the doxycycline and the statins can reduce risk of propagation, but who knows if they've got her on those as well. So you can do a radiological follow-up. So I found one article that suggested that you do a CT at 3 months and then another CT at 9 months and then 12 monthly surveillance, and that's if the aortas are greater than 5 centimetres, and at every 2 years for the aortas that are less than 5 centimetres. So this lady, I found her dissection in August 2018. She's had nothing with us since. So she might be being followed up privately, but like that's been 6 months. She hasn't had anything yet. The other thing I wanted to point out was an acute dissection is anything that's 2 weeks old, and chronic dissection is anything that's after 2 weeks old. So we don't know when hers started, but I think we can assume it's chronic because she's had no symptoms, so she's probably been there a while. So they might decide later on with her, if she develops problems, to actually do some surgery. So you'd operate on her if she suddenly develops symptoms, which would probably indicate a propagation of the dissection. If her aneurysmal sac is bigger than 5.5 centimetres or is getting bigger in 4 mil intervals, and if they can't control the hypertension, they might just go, well, we'll just fix this so that there's no risk of it propagating unexpectedly. And they can do it either open surgery or deploy the stents. End of story. Has anyone got any questions? Excellent. Sorry, I don't have chocolates, unlike Cam.